Thanks so much, Jim, and thanks to everyone for joining us today. I'm Christine Garver-Apgar, and I am the Research and Evaluation Director at the Behavioral Health and Wellness Program. And I'm so excited to be here today talking about some really exciting results from this criminal justice tobacco cessation equity project today. And I'm also really pleased and delighted that Dr. Michelle Hom could join us today. Actually, I think I just said that wrong. I think it's Ham. Michelle can correct me. And from Leonard's Consulting, who was integral in performing the evaluation for some of this work as well. So we're really lucky to have her joining us today. I'm going to just introduce today's webinar, but then I'll turn it over to Michelle in just a couple of slides from now and let her introduce herself a little bit more completely. So as Jim said, we're going to be reporting on some results from the Department of Corrections Cessation Pilot Outcomes Project. And let's see here, let me advance my slides. The objectives today, we're first going to describe how the Justice Involved Cessation Project began in Arizona. I'm going to let Michelle go through that information with you. And then we're going to present results from an evaluation of two cessation curriculum. First, we're going to talk about a little bit about ALA's Freedom from Smoking program, and that was implemented in year one of the pilot project. And then I'll talk more about BHWP's Dimensions Tobacco-Free program, which was implemented in year two of the pilot project. And we'll finish up talking about some more general comparisons of the two programs, and we'll offer some recommendations for adopting justice-involved cessation programming within prison settings. But really, the recommendations could apply more broadly to justice-involved settings and even to other settings more broadly. So this audience hardly needs reminding of the scope of this problem or the rationale for why a pilot project like this might be necessary, but it's really hard to present results like these without a brief reminder of these stark statistics of tobacco and nicotine use in the justice-involved population versus general populations. So just as a reminder, in the US, approximately 21.3% of adults and an estimated 23% of youth between the ages of 12 and 17 report using some kind of tobacco or nicotine product. Whereas the smoking rate among incarcerated men in either jails or prisons is 3 times higher than the general population, so between 70 and 80%. And similar prevalence rates have been reported for women who are incarcerated, and studies suggest that smoking rates among individuals in community corrections are comparable to those who are incarcerated and remain much higher than the general population, so more than 70% in community corrections as well. And of course, we know that it's a myth that individuals within prisons and jails have little or no desire to decrease tobacco use. Most individuals who use tobacco in the justice system have a desire to quit, but cessation programs and interventions vary quite considerably across the correctional system. Quit rates for incarcerated individuals are less than the general population, but they're still substantial. When incarcerated individuals get robust treatment, quit rates can be as high as 12%, even after 1 year, while individuals are still incarcerated in their smoking facility or 3 weeks after release to the community. Studies have shown this. But it's also still the case that empirically validated treatments tailored to this really vulnerable population are still notably absent from the scientific literature. And that's still the case despite the increase in tobacco and smoking bans within the correctional systems. So that's why we're here. And I would like to turn it over to Michelle now so that she can better introduce herself and also her role in this project, and sort of explain how it came to be and kind of how we got started.
Thank you, Christine. So I'm Dr. Michelle Ham, and I'm representing Leonard's Consulting, which was brought in as a partner with the Arizona Department of Health Services to really kind of oversee this project from when we began it was June of 2018. So the project itself was a 2-year project, and it really started by a proposition by ADHS to a governor's work group on recidivism. So the governor is very set. I think he remains that way and steadfast in really helping to reform our criminal justice system and helping individuals that have been incarcerated become better citizens within society upon their departure. And so part of this was the development of the Second Chance Centers, which is the area in which the program setting really took place. We looked at this as an opportunity to really move the cessation needle for the state of Arizona. So this is a hard to reach population, like Christine alluded to. They're underserved in terms of tobacco support and tobacco cessation methods. And so there's a really great opportunity. We can actually probably see some of our statewide numbers on tobacco usage decrease with effective programming within our criminal justice systems. The Second Chance Centers was really provided us with a great audience to have this project really be developed for. And the reason being is that they're selected, they are focused. This is a population in which they are moving into a 12-week trial where they're given skills and resources necessary to re-enter society successfully. So this is a great opportunity where we've already got their attention. They're already attending classes. They're already kind of in that learning to readjust to the outside world in their mentality. So it gave us a perfect audience for this. Again, we had 2 years of this project, and we had different community partners within each one. ADHS was obviously the leader of both years with the Arizona Department of Corrections. We utilize Ashline Resources and American Lung Association a lot more strongly in the first year than we did in the second year. And then in the second year, we actually we kind of brought down the Ashline resource to the very end, and I'll talk about that in a little bit. Along with the ALA, we switched curriculum because we used ALA for their curriculum, and to the Behavioral Health and Wellness Program curriculum, or the Dimensions curriculum. And if you want to advance the slide, Christine. So to go into a little bit more detail on the initial pilot, so I'll call the first year the initial pilot, and then the second year the extended pilot, because we moved into much more of an extended look at the whole process. The curriculum we used in the first section, or in the first set of classes, was the American Lung Association's Freedom from Smoking. This is consistent of 8 90-minute sessions delivered over 7 weeks. So 1 week they have a 2-session week, but each of the other sessions they meet on a weekly basis. The curriculum is designed for the general population, so there were some adaptations that we needed to make to the curriculum in order to present it to the justice-involved population. With the facilitation, we actually broke that into 2 phases, learning from our first phase and moving it into the second, and making some changes kind of on the fly there in the middle of the fiscal year. So the facilitation, we had during the first phase external ALA trained facilitators that came in and actually delivered curriculum to the participants. And we realized in this area that it was hard to schedule. It's hard to schedule external folks. It's costly. Each of the external trainers was given a stipend plus travel expenses and things like that. So those things got a little bit more challenging to facilitate. And so we ended up transitioning to a peer facilitator role in phase 2. Whereas we had trained facilitators that were within the criminal justice system already. They were peer specialists. They were already trained in things like substance abuse. So they were a natural fit for tobacco education and cessation programming. So we ended up training them and utilizing them in phase 2. for the whole first year of the project, the NRT was provided as part of the program by the American Lung Association. So these were all just pieces of the program that were developed. I'll pause for a minute. Is there any questions on the first phase of the program? Okay, so let's go on to the second phase. So the extended pilot, we did a pretty significant program evaluation after the first year, and with those came up with some recommendations on an extended pilot to really make sustainability and the opportunity for this to exist beyond the evaluation period more significant. And so with this, we were able to extend the pilot. When we extended the pilot, we looked at flexibility in training. That was one thing about the American Lung Association curriculum, is it was very strict and very stringent and not super flexible. So when we were introduced to the Dimensions program, the Dimensions curriculum is designed specifically for the justice-involved population. It's 6 90-minute sessions. The format is flexible, so we're able to do once a week, twice a week, every other week. There's just so much more flexibility in terms of how the program can run. So we ended up doing that. With this extended pilot, we really started to focus on just one location. So what I failed to mention earlier is with the initial project, we were in the Second Chance Center at Lewis, also at Piestewa with the women. However, with the women, that's a working yard, so most of the Second Chance Center women were not able to join, so it was open to fill the class with the general population. So for the extended pilot, we were able to just focus our attention on Lewis. They have a greater population. There's more men coming in and out of that program, so it really gave us kind of a better opportunity of filling classes than did Piestewa. Again, with this one, we solely relied on the peer facilitators as the facilitator to facilitate the program throughout. So there was no external, everything was done logistically, scheduling, marketing, you name it, it was done internally by the peer facilitators. At this point, ADHS did help us to provide the NRT for the program. And, we'll kind of go over some of the results with these, but we definitely felt that the NRT was a very big benefit to the program. There is definitely also a benefit to having that peer facilitation. Obviously, there's the cost. The individuals are able to work for free. It's a great win for them. They're able to develop skills that they can use post-release. So those are some positives. They also can provide that lived versus the clinical experience. So one of the things we realized with the first go around of sessions is that the clinicians have a very clinical expertise about tobacco and tobacco control and tobacco cessation. However, the peer facilitators, they live this experience, they understand this population, they're part of this population, so there's a different relationship there that we found was valuable with holding the participants accountable. Class management was also a little bit better with the peer facilitators. I think sometimes the participants might have tried to pull the wool over the eyes of the ALA facilitators, whereas no excuses were able to fly with the peer facilitators. So, and that really kind of sums that piece of it up. I'm going to turn it back over to Christine so that she can really go into depth about the Dimensions project and the Dimensions program rather, and what it means.
Thanks so much, Michelle, for that introduction and getting us through the first year of the pilot project. So most of the results that I'm going to present today are from the Dimensions Tobacco-Free program, which, as Michelle said, was administered as part of the extended pilot project in year 2. So I just want to spend a few minutes describing what that program is. It's an evidence-based tobacco cessation program. It's designed to teach providers, but as of course, as we're talking about today, peers, and really professionals across a broad range of the healthcare spectrum how to successfully negotiate the treatment of tobacco cessation in really a broad range of settings. And of course, in this case, it was tailored specifically for justice-involved populations and settings. So for this program, trainees learn motivational engagement strategies. They also learn community referrals because we know that not every organization is equipped to provide all aspects of cessation services. So really knowing what's around the community can be really important for people facilitating the program wherever they're at. It includes educational activities and then how to provide individual and group treatments, and then policy change strategies for different organizations. So the program teaches trainees the skills and the resources to promote positive behavior change for individuals who are interested in living tobacco-free. The program is a train the trainer model, so that when people finish the training, trainees have the knowledge and the materials to train other individuals to become program facilitators at their organization. And we think that's important for sustainability of any program. So when people go through the training, they get the training manual, of course, and then they also get a group facilitator manual, which provides all the resources and the handouts and the lessons plans and things like that that they would need to run the 6-week tobacco cessation group. Let's see here. I'm having trouble with my mouse and my trackpad, so I'm having trouble advancing my own slides. Here we go. Okay, and program participants are trained in the tobacco-free group curriculum to run at their organization. So the role of the group is really to build awareness about the importance of healthy lifestyles more broadly, and also to create a positive social network. So the group does this through wellness education, group discussion activities, and group facilitators teach participants strategies for stress management and behavior change. But we really feel like the social support that participants gain is helpful. And I think we'll speak a little bit to this later, but I think particularly for this justice-involved population, that social cohesion was evident in these groups. So as Michelle said already, our program it's designed to be run weekly, but as Michelle noted, it's flexible in how it can and has been implemented. It takes 60 to 90 minutes. The group is designed to be an open group, which means that participants can join at any time. They don't necessarily have to come in for session 1. They can join anytime. They don't have to wait for a new session to start. Some information does build on the previous sessions, but it's not totally necessary to have started with session 1. Participants can attend as many sessions as they need to, and then the session topics cycle throughout a 6-week period. So here are the actual sessions. I'll just go over what actually goes on. Session A, envisioning a tobacco-free life. Of course, it's designed to help group participants visualize what a tobacco-free life would be for them. Making a tobacco-free plan. The next session, it's designed to help participants explore their values and their preferences, and then how creating a tobacco-free plan is consistent with those values and preferences. The next one, mindful tobacco-free behaviors, is about helping participants increase their awareness of cravings and create mindful ways to manage those. So for example, identifying triggers and ways to cope with stress. The next one, a tobacco-free journey, is about helping group participants recognize their own strengths and identifying resources that they have or will need. So for example, identifying alternative behaviors and maybe anticipating relapse situations and identifying alternative strategies. Session E, Living Tobacco Free, is designed to help people recognize the interconnection between thoughts, feelings, behaviors, and living tobacco free. So, for example, identifying enjoyable activities that don't involve tobacco, identifying automatic thoughts and alternative responses. And then lastly, session F, maintaining a tobacco-free life. Activities in that session are designed to prevent relapses by planning ahead and managing relapses by getting back on track as soon as possible. So that's the group. That's kind of what it's about. So at every session, participants are asked to complete what we call a personal progress form. And that's to document the progress that they're making during the group. And I wanted to show this to you because the results that I'm going to be presenting on today are based pretty much entirely on participant responses to this form right here. Participants see this form every week, so they become very familiar with it, and it doesn't take very long for them to complete, just a few minutes. So I sort of want to show this to you because I want you to come away from this presentation with the idea that you can actually do a lot with your evaluation without it being a time-consuming, burdensome process for participants and for facilitators and organizational staff. So as you look at this form, what you're seeing is a question that asks, basically we're getting some demographic information, just a few questions. And then we ask during the past week, which type of tobacco or nicotine were people using? We're asking how many cigarettes or other tobacco products a person smoked or used in an average day. During the past week, whether people used nicotine replacement therapy, and if they did, how often they used it. Whether we're asking whether they've made a quit attempt since the last group. And if they did, what was the longest time they were able to stay quit since that last group? And then lastly, we're asking a series of scaled questions that are on a 0 to 10 scale, ranging from strongly disagree with the statement to strongly agree with the statement. And those questions are having NRT available when I need it is important for helping me live a tobacco-free life. And then we're asking some questions to assess, we characterize all of these items as readiness to live a tobacco-free life. So things like having the knowledge that people need to live a tobacco-free life after their release, planning to take steps toward living a tobacco-free life, being motivated to live a tobacco-free life, being confident in their ability to live a tobacco-free life, and knowing that they have the support that they need to live a tobacco-free life after release. And we think these are important questions to gauge intent. And partly this is important because this is a really difficult population to follow up with long-term. You know, Michelle can speak more to this later if people are interested, but this was a group that, you know, Michelle's team tried to follow up with. It wasn't for lack of trying, certainly, but following up with this group of folks after release is really, really hard. So getting some information about sort of future intent we thought was important with this evaluation. Okay. All right. So the program at the Eagle Point Second Chance Center, as Michelle mentioned, this was facilitated by peer support specialists. Actually, I should pause and I want to just double check with Jim and make sure that nobody has had any questions up till now.
So far, so good.
Okay, I'll keep going then. Thanks, Jim. So, as Michelle said, inmates who were trained in the curriculum were selected to teach classes at the Second Chance Center. So that's who we had, who trained in the Dimensions curriculum and who ran these groups and collected the data. There were 3 groups that were run between December of 2019 and March of 2020. The groups were run either twice a week for 3 weeks, or the last group was run once per week for 6 weeks. And then the groups at the Second Chance Center, I mentioned earlier that our program can be run as an open group, which means people can just join whenever they want to. They don't have to wait for session 1 to join a group. In this case, the groups at the Second Chance Center really were run as a closed group. And that's just because attrition was really low. And also the Second Chance Center was large enough that they had no trouble consistently filling groups with folks starting in session 1. So I did want to point that out. In this case, the groups really did operate like a closed group. We didn't actually have people joining in the middle of these groups, despite the fact that our group is flexible enough for that to happen. Of course, evaluators always love it when things happen this way because it does make the evaluation nice and clean. All right. So all of the individuals involved with the program were men. I didn't break down the race and ethnicity on the slide, but just over a quarter of the individuals identified as Hispanic or Latino, just over half identified as non-Hispanic white individuals, and then 21% reported as African American, and 13% reported as American Indian or Alaskan Native. Almost the entire sample reported smoking cigarettes in the week preceding the first group session. So this was really a group of people who are smokers. Additionally, 31% of the folks attending these groups reported using chew. And other than that, there was very little reported use of any other type of tobacco among the men at the Second Chance Center. I think maybe 1 or 2 individuals reported vaping, but other than that, there was no additional type of tobacco use or nicotine use among these individuals. And the graph on the right shows how much tobacco people reported using per day the week before they came to the first session. So this is really a sort of a baseline tobacco and nicotine use frequency charts when people were sort of coming into their first group. So we had 13% of people reporting that they smoked only 1 to 5 cigarettes per day. The key here says cigarettes because that really is the vast majority of what people were using. But the question actually asked how many cigarettes or other tobacco products did you use or smoke in an average day? So this includes people's using other tobacco products as well. So 13% reporting 1 to 5 cigarettes or other tobacco uses per day. And then the majority of folks were split between smoking or using tobacco either 6 to 10 cigarettes per day, or closer to like a pack of cigarettes per day, 11 to 20. And then another 13% smoking more than a pack a day. And then there was no reported use of any FDA-approved cessation medication for folks coming into their first group. So no NRT use until people came to their first group. And as Michelle mentioned, NRT was provided as part of their group participation. All right, so how did people do? First, I I should mention that attrition was really, really low in this sample. This isn't on a slide, but more than 3/4 of the sample, so about 80% of the people attended all 6 tobacco-free group sessions. And 90% of the sample attended at least 5 out of 6 sessions. So that really is very low attrition, excellent attendance for this sample. All right, so first I want to report on quit attempts that people made. 78% of the group participants reported making at least one quit attempt during the course of their group attendance. So that's what's shown in this green section of this pie chart here. And then of those, most of them, all but 6 people, reported that their quit attempts lasted at least 1 day or longer. So that's what's shown in this section here. It was also the case that of these folks here making a quit attempt, over half of those people reported making multiple quit attempts. So they reported making quit attempts on 3 or more of the weeks preceding a group session. And 5 people reported making quit attempts every single week they participated in group sessions, which I think demonstrates that people were really engaged in their cessation efforts, even if they didn't end up quitting during the group. They were trying. They were quitting, every week. They were reporting that they were trying to quit, or on multiple weeks. All right, so what was the quit rate of people participating in the Dimensions group? Out of 37 total individuals across all 3 groups, 9 people quit by the end of their group participation, which amounts to a 24% quit rate. Most of these individuals quit during the second half of the 6-week group session. So by session 4, 5, or 6, they were reporting that they had not used any form of tobacco or nicotine in the preceding 7 days. And Michelle, I'm going to let you chime in here and tell folks how this compared to the ALA quit rates that you saw.
Thank you. Yeah, so we really saw very similar quit rate results with the American Lung Association curriculum. So we do know that the curriculums in terms of the opportunities for quitting were both adequate, or both very successful, I should say. I think that a lot of that had to do with the fact that we had the NRT available to the participants. So that's one of those factors that definitely plays a role in the success rate of quit attempts, plus the support of the groups. So we did see very similar results. But I also wanted to join, or to kind of point out a couple things. So as Christine mentioned earlier, we had 3 groups that were ran with a Dimensions curriculum. The first 2 groups met twice a week, with the last group meeting once a week. And a couple things that we noticed that the facilitators did upon themselves during the course. And that was, one, the first 2 groups, they didn't have a designated quit date that was decided on by the group. And the 3rd group did. So we actually started to see the quit rate jump from the first group being 14%, the second group being 20%, and then 38% on the 3rd group. And so, just thinking what does this really mean? Did that having that set quit date actually make a difference for folks actually committing to quitting and being more successful in the long term with it? And so I think it's important to understand that they did just decide on themselves to do that, and then they pushed that forward. The other thing too is it was a 6-week period versus a 3-week period. So there could have also been some opportunities with having that extended level of support and accountability to their facilitators, as well as part of the reasons that there was that big jump in the success rate of their quit attempts.
Great, thanks so much, Michelle. Okay. And of course, not everyone actually quits during the group, but we wanted to examine whether the group had an impact on the amount of tobacco and nicotine use. So we looked at whether the frequency of tobacco use per day decreased for participants over the course of the groups between session 1 and session 6. So these results are based only on the 31 people who attended all 6 sessions. And what you're looking at here is the changing frequency of tobacco use across 6 sessions. So the orange here is the frequency of tobacco uses per day in session 1. So this largely mirrors that first sort of baseline tobacco use graph that I showed you. And the green then is the frequency of tobacco uses per day in session 6. And essentially what you're seeing is that from session 1 to session 6, the frequency of uses is moving from the higher categories. So people who are smoking more than a pack per day or more than half a pack per day down to the lower categories. So only 1 to 5 cigarettes per day or none at all. Or there's still, a few in the 6 to 10 category. The median tobacco use at session 1 equated to smoking 11 to 20 cigarettes or using other tobacco products per day, compared to the median score at session 6, which indicated tobacco use of just 1 to 5 times per day. And then we also wanted to look at whether participants reduced their tobacco use after completing fewer tobacco-free group sessions. And it turns out that by session 3, only 4 participants reported that they used tobacco more than 10 times per day the previous week, which was down from 18 individuals who said that in session 1. So that indicates that 2 sessions were effective at motivating behavior change prior to the 3rd session. So it turns out that people they might need, most of a group to quit, but they don't need the entire group to pretty dramatically reduce their tobacco use. Okay, so just a word about NRT. So by session 6 of the tobacco-free group, participants reported strongly agreeing with the statement, having NRT available when I need it is important for helping me to live a tobacco-free life. So remember, that was one of those scaled questions. So on a scale of 0 to 10, participants' average response to that item was 8.9. So basically 9 out of 10 by session 6. So people really felt that that was a critical aspect of living tobacco free for them. And it was also the case that all 9 individuals who quit using tobacco over the course of their group participation reported using NRT. And each week that they reported NRT use, these individuals almost always reported using NRT multiple times per day, as opposed to just once per day or less than once per day. Most participants did use NRT during their group participation. Almost everybody chose to use the NRT that was offered. So as Michelle noted, this seems to be a fairly critical component of the groups and of participants' success. Although I think Michelle had also, noted, Michelle, you can correct me if I'm wrong, but when you had done some key interviews with folks in the program, they also felt that the group, although NRT was strongly desired, they did, if that's not a possibility, they did feel that the group could still be effective without it. Is there anything else you want to say about NRT, Michelle?
No, that's actually, that was definitely one of the factors that they felt that they could continue on.
Mm-hmm.
If there wasn't NRT, or they'd still be able to host classes and sessions. However, they did feel that it would impact attendance and possibly success rates. So, and really that's not any different than what we see in the literature. We know that a combination therapy works the best for cessation anyway. So what they were seeing and feeling isn't any different than what we are reading in the literature today.
Right. Thank you. All right. And then finally, we wanted to look at whether participants reported a positive shift in their readiness to live a tobacco-free life post-release. So over the course of group participation, we compared participants' responses to those other 5 items across group sessions. So the orange arrows here show where participants were on average on the 0 to 10 scale at session 1. And then the green arrows show where they had moved to on average by session 6. So these results are again based on the 31 people who did complete all 6 sessions. So you can see positive movement along the scales for most of these items, except for the motivation item. And that's really just because everyone in the program, in this particular program, came into the session 1 already, really motivated to live a tobacco-free life. So, but obviously, by the end of the group, people were really pretty maxed out on these scales in terms of all of these different items, which was really nice to see. But in particular, they mentioned that they gained a lot more knowledge than they had before, which is great from sort of a patient activation or health literacy perspective to see that. Okay, and now I'm just going to turn it back over to Michelle briefly so that she can just discuss a little bit further kind of a comparison of the 2 different curriculums that they evaluated over the 2 years of this larger pilot project.
Thanks, Christine. So a couple things that we just really wanted to look at is the main one being sustainability. How can we make this program sustainable in the criminal justice system over time? Also, so with that sustainability, cost and then flexibility are key components to that. So when we looked at the curriculum comparison, we were really looking at it through that lens of cost, sustainability, and flexibility. Looking from the freedom from smoking versus dimensions, the flexibility of the dimensions program, ability to adjust the frequency, the open format for smaller populations really was a benefit to the program. Although the program at Eagle Point didn't utilize an open format, Paiestewa, the yard at Paiestewa would have definitely needed to have an open format in order to meet the kind of the need or the class size opportunities. So looking at that from some of the smaller yards that are around the state. Looking also from that justice involved focus, again, the freedom from smoking, a fantastic curriculum, but it's really geared for the general population, while dimensions definitely focuses on the justice involved population. So most of the techniques and the opportunities and the tips and tricks that the facilitators are engaging, the role playing with the participants is very focused on what they're living day to day versus some of the other things that when you get out, you can do this. And so those were some of the factors that we noticed and that came up in our program evaluation. The setting of the quit date is it's a core component with the freedom from smoking that everyone sets the quit date, and then you have that quit date, and then 48 hours you have another session right after your quit date for that additional support. And so that was very positive with both the facilitators and also with the participants and helping them with their quit success rates with the freedom from smoking curriculum. It's not a requirement in dimensions. However, the peer facilitators, again, they adjusted on the fly for their session 3 and set that date and had phenomenal results. And so, again, was it that they went all 6 sessions? Was it that they set that quit date? Those are some unknowns, but definitely could be a huge factor in the rate going up from 14% in this first session to 38% in their 3rd session. So that was an area where the peer facilitators felt that it was an important component, and so they added it in. And the nice, again, dimensions being flexible, that's something that they could adjust for the need of the given population that they're serving. And then the last one, just with the sustainability, again, the train the trainer model that Christine explained and described is really critical in this opportunity. If there's, sessions that are occurring over the holiday, like our first session did with the extended pilot, where it was coming over the Christmas holiday, getting external facilitators to come out to a prison during holiday time is going to be a lot more challenging, logistically challenging, than having peer facilitators, where this is their audience 24/7. Holidays or no holidays, their days look the same. And so that made it easy. We also look at that cost piece. Freedom from Smoking has workbooks that you purchase, so they're a little bit more costly than the downloadable materials that cost a printer cartridge and paper to the facility. So once they're trained, they get the download. Once they download, they can get the materials for the participants. So it definitely makes that cost opportunity a little bit more significant. So, Christine, from here, you're going into the recommendations, correct?
Yes, that's right. All right, so we've, based on this Justice Involved project in Arizona, we distilled a few key recommendations for cessation programming in prison settings. Although, as I mentioned before, really all of these recommendations would apply not just to Justice Involved cessation programming in prison settings, but would apply to Justice Involved cessation programming in other settings like community corrections, perhaps. And really cessation programming in settings beyond justice involved, like healthcare and otherwise. So the first one, adopting a peer facilitation model. Peer facilitation, as we've kind of been hammering through this presentation, is really a natural fit within justice involved settings. The lived experiences of peers are particularly salient for those using tobacco in prison. It's cost effective. And as Michelle was just mentioning, it does alleviate a lot of the logistical challenges associated with having an outside facilitator. And Michelle just described the issue that they ran into over the holidays. They ran groups on both December 23rd and December 27th, and that probably wouldn't have been possible with bringing in outside facilitators. But also, when they have last minute schedule changes, or they need to use a different room, or something else pops up on the calendar, when you're using peers in inmates, they're right there. So a last minute schedule change is not a problem, whereas it would be for an outside facilitator. And then, that kind of continuity is really necessary in a prison setting. And then, of course, peer facilitation also offers really unique professional development and leadership skills that will be, incredibly valuable for peer facilitators upon release. The next one that we want to mention is the importance of implementing a flexible curriculum. So throughout the course of the 3 groups, as we mentioned, there were several different changes that were made to how the groups operated. So of course, we mentioned that in the first 2 groups, they were run 2 times a week for only 3 weeks, whereas in the last group, they ran it once a week for 6 weeks. And I think that was the method that was preferred. And that provided better support for participant commitment to change. And that's something that, they needed to be able to make that change on the fly, and a less flexible curriculum might not have allowed for that. And I mentioned too that, the program was run as a closed group, but had they needed to run the group as an open group, that would have been fine. That could have been helpful, for instance, if the program had been like a shorter program, shorter in duration, if inmates had been part of the program for a shorter period of time, or if enrollment was limited to smaller numbers of individuals in a particular program. So implementing a flexible curriculum, I think, was really important for the work that was done at the Second Chance Center. Advocate for NRT. Participants, as we talked about, really thought that NRT was important. Um, the staff and the peer facilitators also stress the importance of NRT. It's NRT is likely not a large budget item compared with other medications, and yet we know that co-treatment for nicotine dependence, along with other addictions, so for instance, opioids, that actually increases the success rate of treatment for the other addiction. So if you co-treat for nicotine addiction and opioid addiction, people are more successful with treatment for opioids. And so providing NRT may improve abstinence rates from other substances. It could actually reduce medication costs in some cases. And it also reduces recidivism. So there's a number of cost factors to consider beyond just the increased cost of actually providing NRT. So, you know, there's creative ways to sort of brainstorm how to bring NRT to different programs, but continually advocating for NRT is important. Okay, enhancing the continuity of care. One of the things that this evaluation couldn't do was follow up with participants after they were released to gauge long-term program impacts. And in this case, multiple emails I know were sent about 6 to 8 weeks post-release for follow-up, but the response rate was only 11%. This population is particularly challenging to follow. But we know that in general, relapse rates are really high post-release. One study found that relapse rates were 88% within 3 weeks of release, even with a robust treatment program during incarceration. So developing partnerships with organizations that serve the cessation needs of individuals after release would ideally be a component of any cessation program in a prison setting. So Ashline would be one really obvious key partner in these efforts. And I'm sure that you in Arizona can think of other potential partners that would serve as a continuity of care for cessation services for this really vulnerable population post-release.
Christine.
Yes.
Can I interject really quick before we move on?
Of course.
So with that continuity of care, one of the things that we did during that first initial pilot, we had a dedicated phone line in the yards for inmates to call Ashline, and it was grossly underutilized. So it was a challenge. And so we shifted our partnership with Ashline so it wasn't quite as involved during program, but we actually provided them with a handout on like steps to get NRT post-release and
Right.
how to access Ashline and get set up with a coach. So we were not sure how, because of the tracking, we didn't have the same tracking mechanisms between the initial pilot and the extended pilot with Ashline and the participants. So we're not exactly sure how many actually followed those steps, but we did provide detailed steps and how for them to, one, get into Ashline and get started on their NRT post-release, and then two, those steps that they needed to be able to continue with their NRT through access. So those were definitely thoughts. It was just we need more of a bridge, I think, between when they're released and when we get them into either seeing a primary care physician or accessing Ashline a little bit more specifically. But they were definitely things that we were thinking of in that continuity of care.
Right. Great. Thanks, Michelle. That's a great example of how those efforts can play out. And actually, that's a nice segue into the last item, which is to evaluate continuously these programs. And ideally, of course, that evaluation would continue after release. And that's always a challenge, but developing those partnerships with organizations that can help with that continuity of care piece, that can also serve as part of that evaluation piece too, and can actually help, ideally in the future with trying to keep track and follow up with these folks post-release. So we sort of view that as all, part of the same effort. But just if there's one thing that I hope that, you have taken away from this presentation, it's that you can actually discover a wealth of information with an evaluation that is not very burdensome or time consuming. We think people are able to to complete that personal progress form in just a couple of minutes every week, and it provided all of the data that we've been able to share today, and that includes things that are good to know when we're moving the program forward. So a lot of the things that we've been talking about, how the importance of NRT, and whether the program is working, and the things that we need it to do better, or and the things that that maybe didn't work as well initially, but then changes that were made and how those improve the quit rates. Those are all really valuable things to know going forward for any program. So if you're not evaluating, you don't know what's working and what isn't, but perhaps even more importantly, you can't get credit for the really good work that you're doing. And by credit, of course, we all know I'm often talking about funding. We're really talking about continuous funding for your work, for the really good work that you're doing for these vulnerable populations. So I encourage you to think about evaluation at the very beginning of your efforts to implement a new program, or to inject some cessation work into your organizations, if that's something that you're thinking about doing. So is all the official slides that I have, and I just wanted to close with some questions and discussion. I want to first see if anybody has any questions for either Michelle or I.
So nobody's used the Q&A function, and nobody's chatted in anything, but I do want to remind folks that if they want to use the raise your hand function at this point, we can allow you to talk, and you can just ask your question using your voice and your computer microphone. While we wait for people to chime in here, Christina, I noticed that on your on the various readiness scales, that slide with all the scales on it, that there seems to be a pretty hard stop around 9.5. And I was just wonder if, from an evaluator standpoint, if you just think that's like people being reluctant to give perfect 10 out of 10s, or if there's something, as since I trained this program, if there's something as a trainer or as a content creator, things we can do to push people further up on that ladder.
Well, it is hard to go past 9.5, and I do think there is a bit of a reluctance to max out the scale. That's actually one reason why this maybe goes into some, I don't know, maybe technical issues, but that's one reason I prefer scales that actually have more numbers on them than, like, say, a 0 to 5 scale or a 1 to 5 scale. A lot of people like to use just 1 to 5 scales, but I find that sometimes it's hard for people to say either 0 or 5. They just tend not to use them, and so then in that case you're really only looking at 2, 3, and 4, and so it's harder to document change when people aren't willing to go all the way up and all the way down. So that's one of the reasons why I like those scales that have more numbers. I think it's a little bit easier to document change when you're not expecting 25 and 50% change necessarily. So I don't know that there's anything you can do as a trainer, but I do think there's something to that.
No, I prefer that answer because I don't like working any harder. I kid, guys, I kid. So we are at time, and no further questions have come in. I do want to go ahead and invite everybody. The way I normally, I run learning community calls for a variety of different programs, and the way when something like this would normally show up in one of those, in that context, I would normally say, what do you need to know if you're a program designer? What would you need to know from Christine or Michelle to replicate this in your district, whatever that is, your county or your organization? And and that's, I feel like that's the way to like really close the gaps on what's been presented. I think that what you guys presented today was great. I think it was super informative. Even as the person who trained the peers and some of the COs in this program, it was great to see the results. Because I hadn't really seen them before. But that doesn't mean it's everything, right? So, I mean, those of you who are on the line, people are starting to file off. What do you need to know if you wanted to replicate this? Not that you should, but feel free to, you all have my email address, you all have Chad's email address. Shoot us those questions, and if Chad and I can't answer them, then we'll definitely rope Christine and maybe even Michelle back in to close those gaps for us. But with that in mind, I think that we should probably just go ahead and say thank you again to the doctors, Ham and Garber Epgar, and we'll talk soon.
Thanks so much, everyone.